Welcome to this presentation on some clinical uses of anticoagulants, Part 1. In this session, we will explore the pharmacotherapeutic use of anticoagulants, focusing on their role in the prevention and management of thromboembolic disorders. We will integrate guideline-based recommendations with clinical reasoning to understand how these agents are applied safely and effectively in practice. Let's begin with one of the most important therapeutic areas, stroke prevention in non-valvular atrial fibrillation. Atrial fibrillation, or AF, is the most common sustained cardiac arrhythmia encountered in clinical practice. The condition is characterized by rapid and disorganized atrial electrical activity, leading to ineffective atrial contraction. This results in blood stasis, particularly within the left atrial appendage, predisposing patients to thrombus formation. When dislodged, these thrombi can travel to the cerebral circulation, causing ischemic stroke, a leading cause of death and long-term disability in AF patients. Importantly, AF increases the risk of stroke by nearly 5-fold, and the severity of stroke is often greater than in non-cardioembolic cases. Therefore, anticoagulation remains the cornerstone of stroke prevention in atrial fibrillation. Understanding the type of AF is crucial before initiating anticoagulation therapy. Non-valvular atrial fibrillation, as defined by the 2024 ACC/AHA/ACCP-HRS guidelines, refers to atrial fibrillation in the absence of moderate to severe mitral stenosis or a mechanical heart valve. This distinction matters because patients with mechanical valves or rheumatic mitral stenosis require vitamin K antagonists, not direct oral anticoagulants, for effective stroke prevention. Conversely, patients with non-valvular AF can be safely treated with either warfarin or direct oral anticoagulants, depending on their clinical characteristics and risk profile. Before initiating anticoagulation, it is essential to quantify a patient's stroke risk using the CHA₂DS₂-VASc scoring system. Each component represents a clinical risk factor. Congestive heart failure, hypertension, age equal or 75 years, diabetes, prior stroke or TIA, vascular disease, age 65 to 74, and sex category, female. A score of 2 or more in men, or 3 or more in women, strongly supports the need for anticoagulation. Patients with intermediate scores may require individualized assessment considering both bleeding risk and patient preferences. Before initiating or continuing anticoagulation therapy, it is essential to assess the risk of bleeding alongside the risk of stroke. The HAS-BLED score is a validated clinical tool used to estimate the annual risk of major bleeding in patients with atrial fibrillation who are being considered for anticoagulation. Each letter corresponds to a modifiable or non-modifiable risk factor. H. Hypertension, uncontrolled systolic blood pressure greater than 160 mm of mercury. A. Abnormal renal or liver function, 1 point for each. S. Stroke, prior history of stroke. B. Bleeding, previous major bleeding or bleeding predisposition. L. Label INR, time in therapeutic range less than 60%, applies to warfarin users. E. Elderly, age greater than 65 years. D. Drugs or alcohol, 1 point for each, e.g., antiplatelets, NSAIDs, or heavy alcohol use. The score ranges from 0 to 9, with 0 to 1 equals low risk, 2 equals moderate risk, and greater than or equal to 3 equals high risk of bleeding. A high HAS-BLED score does not contraindicate anticoagulation, but rather highlights the need for caution and regular monitoring. Clinicians should focus on modifying reversible risk factors, such as controlling blood pressure, reducing alcohol intake, reviewing concomitant antiplatelet or NSAID use, and ensuring INR stability in warfarin-treated patients. The goal is not to deny anticoagulation but to balance and optimize safety, ensuring that the stroke prevention benefits of anticoagulants clearly outweigh the potential bleeding risk. For most patients with non-valvular atrial fibrillation, direct oral anticoagulants, DOACs, including apixaban, rivaroxaban, dabigatran, and edoxaban, are preferred over warfarin. This preference is based on multiple large randomized trials showing similar or superior stroke prevention with less major bleeding, especially intracranial hemorrhage. Warfarin remains indicated in patients with mechanical valves, rheumatic mitral stenosis, or severe renal impairment, creatinine clearance below 15 to 30 ml per minute, depending on the agent. The selection of a DOAC should consider renal function, hepatic function, potential drug interactions, and patient adherence. Warfarin is a vitamin K antagonist that inhibits the synthesis of clotting factors 2, 7, 9, and X, as well as proteins C and S. Because these are vitamin K-dependent factors, warfarin's onset of action is delayed until pre-existing factors are depleted, usually requiring 3 to 5 days. For this reason, warfarin is sometimes bridged with a parenteral anticoagulant, such as low molecular weight heparin, when immediate protection is needed. The therapeutic range is defined by the INR, International Normalized Ratio, with a goal of 2.0 to 3.0 for stroke prevention in AF. Warfarin therapy requires regular INR monitoring due to its narrow therapeutic index and numerous interactions. Drug interactions occur through the CYP450 system, particularly CYP2C9, CYP1A2, and CYP3A4. Enzyme inhibitors such as amiodarone, azole antifungals, macrolides, metronidazole, and TMPSMX increase INR and bleeding risk. Enzyme inducers such as rifampin, carbamazepine, and phenytoin decrease INR, reducing efficacy. Dietary vitamin K also affects warfarin response. Increased vitamin K intake lowers INR, while reduced intake or gut flora alteration from antibiotics increases INR. Consistent dietary habits and medication reconciliation are essential to maintain therapeutic balance. DOACs are classified based on their mechanism of action. Dabigatran is a direct thrombin inhibitor, factor IIa inhibitor. Apixaban, rivaroxaban, and edoxaban are factor Xa inhibitors. These agents have predictable pharmacokinetics, fixed dosing, and do not require routine INR monitoring. They provide rapid onset and offset of action, allowing easier initiation and perioperative management compared with warfarin. While DOACs simplify therapy, clinicians must recognize their key limitations and interactions. All DOACs are substrates of P-glycoprotein, PGP, and some also depend on CYP3A4 for metabolism. Strong inducers, e.g., rifampin, carbamazepine, phenytoin, St. John's wort, markedly reduce DOAC levels and should be avoided. Strong inhibitors, e.g., ketoconazole, itraconazole, clarithromycin, ritonavir, increase plasma concentrations and bleeding risk. Renal elimination is significant, about 80% for dabigatran, 50% for edoxaban, 35% for rivaroxaban, and 25% for apixaban, making renal function assessment crucial before prescribing. In certain clinical scenarios, such as patients with atrial fibrillation who also have coronary artery disease or have undergone percutaneous coronary intervention with stenting, anticoagulant therapy alone may not be sufficient. These patients require antiplatelet therapy to prevent stent thrombosis and recurrent ischemic events. However, combining antiplatelet and anticoagulant agents markedly increases the risk of major bleeding, especially gastrointestinal and intracranial bleeding. Therefore, the primary principle is to use the minimum effective combination for the shortest possible duration. Initially, triple therapy, consisting of an oral anticoagulant, aspirin, and a P2Y12 inhibitor, may be indicated, but usually only for up to 1 month after PCI, and only in those at high ischemic risk. Clopidogrel remains the preferred P2Y12 inhibitor due to a more favorable bleeding profile. After this early period, dual therapy with an oral anticoagulant and a P2Y12 inhibitor is continued for up to 12 months, depending on the type of stent and bleeding risk. Finally, monotherapy with the anticoagulant is typically maintained for long-term stroke prevention. The use of a DOAC is preferred over warfarin, as multiple trials have demonstrated reduced bleeding without compromising ischemic protection. Additional measures to minimize bleeding include prescribing proton pump inhibitors, avoiding nonsteroidal anti-inflammatory drugs, and preferring radial access PCI. Ultimately, the goal of combination therapy is to strike a careful balance, maximizing protection from both thrombosis and stroke, while minimizing the risk of bleeding. Transitioning between anticoagulants requires careful planning to maintain continuous protection while minimizing bleeding. For example, from rivaroxaban to warfarin, stop rivaroxaban and start both a parenteral anticoagulant and warfarin at the next scheduled dose. Continue bridging until INR exceeds 2.0. This approach is needed because rivaroxaban can falsely elevate INR, making early readings unreliable. Similar principles apply when transitioning between other DOACs, parenteral agents, or VKAs, as guided by pharmacokinetics and half-life. To summarize, anticoagulant therapy in non-valvular atrial fibrillation aims to prevent thromboembolic stroke through individualized, evidence-based pharmacologic choices. DOACs are now the preferred agents for most patients due to their predictable profiles and reduced intracranial bleeding risk. Warfarin remains essential in certain clinical circumstances, especially mechanical heart valves or severe renal impairment. Safe and effective use requires continuous assessment of renal and hepatic function, drug interactions, adherence, and bleeding risk.